Rahman Rahim. Welcome everyone. Thank you for joining our webinar today for the 30 minutes. I've actually been an examiner in the Royal College of Surgeons of England over the past 10 years, and I thought to summarize my experience to doctors going to either OSCE exam part B or going to MD in surgery or in vascular or the Egyptian fellowship program. I've seen a lot of mistakes from candidates. Not all mistakes are missing knowledge. Some of the mistakes are actually due to unable to do the technique itself. You can unmute yourself at any time and you can ask a question. I will speak today about one of the common OSCE station that you will be asked upon, which is the OSCE station of excision biopsy. Have anyone seen the station excision biopsy? You can unmute yourself and answer. Probably you haven't much. In this station, you are being asked to excise a small lesion and to suture it. It is done on plastic model. Here we need to, what is the examiner is looking for? The examiner is looking for your knowledge. How much knowledge do you have? Can you perform this procedure with competence or not? So here I've put the learning curve. You can see lecture will give you retention rate, which means you have retained your information only 5%, like what I am doing now. You only get 5% retained. Start read about the topic, you get 10%. If you see audiovisual, which I get a video, your retaining will go up to 20%. If you demonstrate it to your colleague, and I will ask you to record your OSCE station and show us what you are doing, you get 30%. If you discuss it in the group, you get 50%. If you have information asked in an exam, it is printed in your memory, you get 75%. So this is important for you to remember. You don't just need to read a book. You must have this learning curve in the top of your mind. What is the examiner is looking for? If you don't know, which means ignorance, or incompetent, you will not pass. You will never pass the exam. If you don't know what to do, if you're doing it but incompetent, you will not pass. You pass if you are competent and if you perform with excellency. Here you will pass, here you will get a full mark. So this is what we are looking for. And it needs training. And this is what the examiner is looking for. I am looking at you to see, are you confident doing the procedure, excision, or are you hesitant? Are you having steps in your mind or not? Or are you doing it properly? Is the patient safe in your hand? What about your manual skills? How you are taking the sharp needle, putting them away? How you apply your knowledge? How you summarize and to get me a comprehensive conclusion? And what is the level that you know about this topic? How much knowledge do you have? And can you communicate this knowledge to me and to patient? This is what I'm looking for. And this is what I will give you the degree on. Now, in OSCE station, there is a marking sheet. This is how we assess you. We assess according to a sheet. And remember, if you are an examiner, there is no veto station. So if I make you fail in this station, you still can pass the exam. Because in the past, it used to be 17 OSCE station. Now after COVID, it has become 13. And you pass if you have failed one station. If you failed 2 stations, you will not pass. So there is no V2 station. So this is important for you. I get this question a lot from candidates. This is very stressful exam. You get so many stations beside. What I tell them, well, and it is very stressful job. To become a surgeon is not an easy job. It is very stressful. So we test how you behave under stress. This is the sheet. I wouldn't go into detail here, but this is how I put your marking sheet. And I put degree in every step of the way that you are doing. So how to prepare for the exam? This is very important. A lot of people doesn't know, think I have to read books. No, you need to practice. You need to examine yourself in OSCE station. You need to read around the topic. You need to discuss it with another colleague. You need to attend training for OSCE, because a lot of medical school got training from year 1. Here for us in Egypt, we don't get OSCE training. We only get it during the exam, but during the whole medical school, OSCE was unknown. And this is the standard way of measuring your medical skills. That is why when I examine doctors in Maadi Hospital in Cairo, there is a big difference between their level and when I examine in London because of the education. And this is here I summarize how you prepare for an OSCE exam. And I've collected also what you do and what you don't. You can review the video. I've collected here the things that you need to do and the things that you need to avoid in this slide. As a good general advice, think that you have 2 examiners. One is blind and the other one is deaf. So for the blind one, you tell me what you are doing because he's blind. And for the deaf one, you show me how you are doing it. And this is a good advice. I've also collected another advices for you to go on. Remember from the last meeting, wiper, then EPA, finally water, and the E-boxes. And this is summarized here, what is meant by each one of them, what you need to do during the exam, EPA after the exam, water. If you got a case, you need to discuss E-boxes, all of them in that order. And this is important, helpful abbreviation. In suturing, I give you a plastic. What you can see here is a plastic with a lesion and cut. And I tell you to prepare the tools. And we get you an artificial arm like this that you need to suture. And this is the tools. And in this station, you are collecting the tools yourself. You pick up the tools that you want, the size of the gloves, the sutures, the needle holder, and which type of needle holder you need to have. This is the plastic. You need to get training about how to do it. Record a video of yourself, and we can discuss it over this scenario. I will show you what you have done right and what you have done wrong. I've collected here a video, which I think is a very nice video to explain what you need to do. It's a plastic model, and this plastic model have an incision, and you are collecting your material and do suturing. Okay, so a bit of the net connection, little bit takes time. So let us see over this 6 minutes. How you can do this station. It's actually 4 minutes and 8 seconds. But believe me, I have seen a lot of people unable to do excision, doing very bad suture, doing very bad excision, don't know how to hold the scalpel. Do you need a pencil grip or do you need a palm grip?
Today's video is going to talk about the excision of a cutaneous lesion. This has come up a couple of times in the exam, so you need to be confident at it to achieve it in the time allotted. The first thing to do is to treat this like any other surgical procedure. So make sure that you've checked your patient, both their identity and their consent form, like any WHO checklist.
This is very important because in the exam, we give you a consent form with name of the patient on it. We put the arm band on the patient with his name. If you haven't checked the consent form is being signed, if you haven't checked the full name, if you didn't explain the procedure, you are losing marks. And we put this plastic sheet on his thigh or his knee or his elbow. And you always have to remember Langer's line. How to do your incision, longitudinal or transverse. Remember Langer's line. Always ask it, and we get a lot of wrong answers.
Make sure you've got all the equipment you need for the procedure. That includes a scalpel, equipment for suturing, and skin prep. The other thing you may or may not need is a pen to mark it.
Does anyone have a question from the participant? You can unmute yourself if you have any question at this stage. Okay, no question. We'll continue.
At your incision. If there's one available, I would always use one. Having checked that it's the appropriate patient, you need to make sure that they're appropriately anesthetized, either under a
I like the candidate in this station to draw before incision, marking. It tells me that you are meticulous. You do the marking, and you need the diameter to be 3 times the length, or the length 3 times the diameter. It's very important. So when you excise, let us say you take 1 centimeter diameter, the length have to be 3 centimeters in order for the wound to be closed primarily. And be very careful using the pen to ask, is it a sterile pen or not a sterile pen? And then show me how you do draping and how you do preparation of the skin and with antiseptic.
General anesthetic or local anesthetic. Local anesthetic infiltration is covered in another video.
Local anesthetic infiltration is important. We'll give you local anesthesia, we'll give you a syringe, and you can inject it inside the skin. And one of the very common mistakes that when you inject, there is a force, you get a spilling over of the local anesthetic all over the place. So be very careful when you do injection, hold the needle in the syringe, and when you finish injection, put the needle in the sharp pen, in the yellow sharp pen. All this have marking on it.
You need to make sure they're appropriately anesthetized. If it's local anesthetic, use your tooth forceps to check that the block is working. Then mark out your incision. It wants to be an elliptical incision, and you need to think that it's going to be 1.5 to 3 times the width.
This is marking. You see how he have a steady hand.
So with your appropriately checked and anesthetized patient, you can now prepare your sterile field. Here we're going to use some chlorhexidine prep to clean the area. While that's drying, you can get the rest of your equipment ready.
We give you a drape already with a hole of offsite in the middle. So it's not like this, but you can ask for a drape and we give you a drape.
You can now begin the procedure. The important thing is your sharps handling. There are 2 ways to hold a scalpel, either like a pen or like this. For fine work, I recommend holding it like a pen.
This is called the pencil grip. You need 1 cut, a skin subcutaneous
Think
tissue.
about the layers you're going through as you make your incision. You don't want to go too deep or too shallow. You do need to make sure that you get the whole lesion. Once you've made your incision, you can then begin to remove the lesion.
You see the movement without hesitation mark, steady hands, regular snaps. His movement of the knife is steady. This is extremely important, and I have seen amazing mistakes in this station.
Having excised the lesion in full.
After you excise it, you said, where is the solution, the preservative solution to put it for histopathology? We like also if you can mark where is medial, where is lateral, where is upper and where is lower. You can have any coding you like. For example, the short suture is medial, the long suture is upward, or any other system. But show me how you put the specimen and how you do orientation.
You need to send that to the appropriate histology. You may, if you wish, place a marker stitch, such as a non-absorbable monofilament, at one end of the lesion, so that you might say marker stitch at most distal or proximal end. That's entirely up to you. You then, if you have the time, should close the wound in an appropriate fashion. For me, I'm going to use vertical mattress sutures with a monofilament non-absorbable stitch. Having closed your wound,
the type of suture you decide on is open. You can do a vertical mattress, you can do simple, but show me why you have selected this type of suture. You show me the reason why you are doing this.
In an appropriate manner and send your lesion for histology. Dispose of your sharps in a safe way. Apply a clean, dry dressing to the wound if one is available, and give the patient advice, saying that their stitches will need to be taken out at 10 to 14 days, and you'll see them in clinic with the results of their histology, which should be ready in, again, about 10 to 14 days at the latest.
So, this is a quick video about this station. And the platform is open for discussion. I will check here that you are, yes, you are able to unmute yourself and ask your question. You are also able to share your screen other than my screen. So let me start, Dr. Ramon. Have you seen this station before, excision biopsy, Dr. Ramon?
Good evening, Dr. Omar. Thank you so much for this presentation. I have seen it on YouTube videos, yes.
Okay, but you haven't seen it in exam or done it in an exam?
I have passed Part A exam and preparing for Part B.
Congratulations, congratulations. You are the one which the result announced today?
Yes,
excellent,
today.
Excellent, well done.
89%.
Excellent, well done. We'll see you shortly. Okay, so what I want you to do, there is a plastic model that you can do suturing. You need to have training about excision biopsy, because this is one of the very common station that we give. And even if in the MED, they want to have a similar station now or examine you in an operating theater. So this is an important technique. Dr. Ahmed Onsi, have you seen this excision biopsy station before?
Yes, Dr. Omar, I have entered the OSCE exam.
Okay.
Part B 2 years ago, and I have not passed the exam, unfortunately. And I wanted to point out that when I inject the anesthesia, the model is rubbery.
Yes.
And even the model is rubber, and even when I inject against resistance.
Yes.
So the needle was not with a lock in the.
Yes.
يعني الموقف ده حصل معايا فعليا.
Yes. Have you examined in Maadi Hospital?
Yes, Dr.
Yes.
Omar.
Okay. Well, I will tell you.
It was an easy station, but
yes.
I did a lot of mistakes in it.
No problem. I will tell you. In this station, it's a plastic model, and the plastic that you inject is very compressed. It's not like subcutaneous tissue that it goes away. So number one, you don't need to inject a big amount, because I'm, as an examiner, want you to show me the steps of injection, putting the needle, put the plunger, and maybe inject 1 mil or 2 mil, not much. But what I need you to do is to hold the needle, because this needle doesn't come with the needle lock. The needle and the syringe doesn't have a lock. So what commonly happens is you suddenly give an injection, you spill all over the place, you don't look professional.
طب please Dr. Omar,
So
another
the
point.
advice,
Yes.
inject 1 millimeter, hold the needle with the syringe.
Yes, sir.
Okay?
Another point, when I injected about 5 milli, the patient when I tested with the toothed forceps, the patient complained that she is feeling a pain.
Yes, this is want the examiner to know if the patient feel pain, are you going to do the excision or give more local anesthetic?
I already had given a local anesthesia again.
Okay, so you either say in ideal situation, I will wait couple of minutes for the local anesthesia to work. If it didn't, I will inject more. And my maximum dose is, so you got a points. You're scoring points. Usually, when we get an actor, usually we have an actor for this. And it tie over the thigh, it put the plastic sheet. That's it. So if I want to test you, what you will do, Dr. Ahmed, if the patient tell you that he feels pain? What I want from you? I want from you to tell me that you will wait 2 minutes. If it doesn't work, you will inject more. And you don't have to wait 2 minutes because you only got 6 minutes to do the gestation, or even 9 minutes. Some people doesn't finish it, but it shows you how professionalism is. But good luck. I'm sure you will pass next lot. And we'll take every station and we discuss all the mistakes and what to do. And this is very common mistakes that we see for all candidates. So Dr. Mohammed, okay. Dr. Mohammed Haridi, do you have any questions? Okay, maybe he couldn't unmute. Dr. Karim Sha'rawi? Dr. Muhammad Tulba have.
Yes, sir.
Dr. Karim.
Thank you so much.
You're welcome.
I don't have any questions, but I'm carefully listening.
Okay,
very good. Also like the comments of my colleagues, and I enjoy them as I do it myself in real life. As you know, I'm not a MRCS candidate. Okay. I already have my MD, so
excellent.
But I do exactly the comments that they do, sir.
Okay.
Like waiting the 2 minutes. Do you feel pain or not?
Yes.
I do it in my real life, so I really enjoy the comments and conversation, and it's very useful.
Very good. And how you are planning your career after your MD?
Well, I passed my MD like I think 7 or 8 years ago.
Okay, very good.
My career is basically
you want to go to European board or FRCS Vasc or what? Because I like also to give a bit of career advice in our 30 minutes webinar. So
I'd love to from you, sir.
Sorry?
I'd love to hear your advice, sir.
Yes, well, my advice,
very valuable for me.
Okay. My advice, I will give you a career advice. Look, sit down with yourself. Let us say after 10 years, what I want Dr. Karim to be in. I want you to be specialized in what specialty. And if you decided what specialty, then what grades or what exam I need to pass, or what training stations or seminar I need to attend, and have it ready next webinar, next Friday, and then we can discuss the best career advice. When I was in UK, we usually give a committee from the Royal College of Surgeons of England, usually the regional advisor. He come to us and give us a career advice, because in Egypt, no one is caring about your career.
Yes, exactly.
No, all what they want is this work to be done. But you, I don't care about your career. I don't care how it's progressed.
Yes.
This is not right. You should be an authority taking care of you. How can I help you progressing in your career? So next time we'll discuss what is your specialty, and in 2030, where do you want to be? And then we can start working on it. So
I'd love to. Thank you, sir.
You're welcome. You're welcome. With my pleasure. So I think we have finished the 30 minutes. I will try to give you every week 30 minutes of discussion about OSCE station, MD exam, career advice, and so on. And this video will be available on YouTube for you and your colleague to review and review the slides as well. I hope it will be in benefit in your career. The career of surgery is prosperous. The rapid changing development in the healthcare work in your advantage, but you need to plan your career well. And
دكتور عمر
اتفضل.
استاذن حضرتك اولا بشكر حضرتك جدا على انك خدت من وقتك عشان المحاضره القيمه جدا ديت، وحضرتك توضح لنا الحاجات المهمه في الاكزام.
قوي.
الحاجه الثانيه، هل في ستيشنز معينه يعني مش هتبقى منشند في الاكزامز بعد كده بسبب الكوفيد؟ يعني هل في كلينيكال بروسيدر بعد ما لغوا بعض السكيلز ستيشنز والباثولوجي ستيشنز والحاجات دي كلها، هل في ستيشنز مثلا في بروسيدر سكيلز بسبب عدم وجود بيشنتس او اكتورز هتبقى اوميتد من الاكزام، ولا
في
نفس اللي كان بيجي؟
في تشينج اوف ريجوليشن، وانا حطيتها في السلايدز بتاعت الاسبوع السابق. هما due to COVID there is no patients. حتى لو انت رحت امتحنت في لندن there is no patients. And there is no actor. So you only are yourself. And instead of 17 OSCE stations, they are only 13 OSCE stations. I have summarized these changes, but there are plenty to give because OSCE is a continuous process. We do OSCE development. So I write an OSCE station, and each station tests you in a certain knowledge. So it's an endless game. You cannot exclude anything from the exam, but hopefully over the next few months, I probably would have covered maybe 70 to 80% of the OSCE station that you had. And sure, you have to be ready for a new OSCE station, because what the Royal College does, not to become constant, we get a pilot station, which means a new station having been in an exam before, and we test it. We don't get mark on it, but we don't tell you as a candidate that this is a pilot station. But we take the opinion of the examiner. If the examiner said it's okay, there is no problem, we put it in another exam as another pilot station. If it passes these two tests, it becomes regular station. Most of the stations that you will see in the MRCS have been there for maybe 5 or 6 years, so have been tried thoroughly. So you cannot exclude a certain topic not to study as an OSCE station. No, but instead of having an actor and having patient, we have a lot of ways that we can examine your skills in this regard. So you still have to know how to examine thyroid gland, how to examine abdomen, how to examine lower limb, how to examine cardiovascular. Sometimes we use plastic model, and sometimes we use iPad. And there is a lot of tricks that we'll use to take this experience from you. So my advice to you, don't think of an exclusion criteria. Don't think of an easy road. The road is difficult, but fruitful. And you need to learn the technique of OSCE station, and then you can pass any station that even you haven't thought about before. But you have the knowledge, you have the steps, you know how it's being done. The problem we have in Egypt that we don't teach OSCE station to medical school year 1. And when they graduate, start to go to London, they found something totally new. They are not prepared. Even the OSCE station now is being in the interview. When you get an interview, we give you a clinical exam. So thank you very much for your participation.
Thank you.
And
thank you.
See you next week.
Thank you.
Thank you.
Thank you, Dr. Omar.